So good afternoon to all. On behalf of Dr. Fadi Farahat, the president of the CRG, Cancer Group Research, and AMAC Group, we are welcoming all of you to our activity, which will be about biosimilars in follicular lymphoma. The activity, as all you know, it's endorsed by ASCO, UICC, and AMAC, and it's awarded by 2 CMEs for each activity. The activity is simultaneously translated to French, so any person would like to hear it in French, you can do it. I will start with Professor Fadi Farahat, who is going to give us the first quiz to test our knowledge. So, Dr. Farhat, the floor is yours.
Hi, everybody. Okay, we'll share. Can you give me the right to share, please? Vanessa. So thank you, Dr. Sami. Thank you for the audience. We are starting our activity about the hematology and biosimilars. Vanessa, I'm not able to share. No, it's okay. Okay. So it will be a fast, as usual, fast quiz about biosimilars and hematology. Which of the following is accurate about the etiology and epidemiology of non-Hodgkin lymphoma? High-grade lymphoblastic and small non-cleaved lymphomas are the most common types of non-Hodgkin lymphoma in elderly. 1. 2. Epstein-Barr virus is associated with development of Burkitt lymphoma, Hodgkin, and sinonasal lymphoma. 2. 3. Or C. Low-grade lymphoma account for more cases of non-Hodgkin lymphoma in children and patients younger than 35 than do high-grade lymphoma. And finally, D. Latent celiac disease is associated with an increased risk of malignant lymphoma. So which of this statement is right? A, B, C, or D? Please vote. So please vote. Can we see the results? So Epstein-Barr virus is associated with the development of Burkitt lymphoma, Hodgkin disease, and sinonasal lymphoma, 60% approximately. And in a previous quiz, the response was also the same, almost 63% voted, almost the same percentage for the same result. I will not go through the rationale. It's well known about the Epstein-Barr virus. So now the second question, which of the following is accurate regarding the presentation and physical examination of patients with non-Hodgkin lymphoma? So it's about the clinical exam and presentation. B, symptoms are equally as common in patients with low-grade lymphoma as in intermediate and high-grade lymphoma. So the B symptoms are the same in low and high-grade lymphoma. The spleen is commonly the only involved site at presentation in patients with low-grade lymphoma. So low-grade lymphoma and the splenomegaly. A spontaneous regression of enlarged lymph node can occur in patients with low-grade lymphoma. And D, A, B, C, and D, patients with lymphoblastic lymphoma present more frequently with a large abdominal mass and and symptoms of bowel obstruction than do those with Burkitt lymphoma. So which is the right answer? Is it the B, A, B, C, or D? Please vote. So spontaneous regression of enlarged lymphoma nodes can occur in patients with low-grade lymphoma. So 50% almost of patients responded, and also it's similar to that was to the percentage of responses by the same quiz done by Medscape previously. You can see that we have almost the same result. So the right answer is C. And indeed, it's well known that we can see some regression like in the low-grade lymphoma. The third question, which of the following is accurate about the workup of patients with non-Hodgkin lymphoma? FDG PET has higher predictive value for relapse than classical CT in patients with non-Hodgkin lymphoma. So the first statement that FDG PET CT has a higher predictive value for relapse than classical CT in non-Hodgkin lymphoma. Lymphocytosis with circulating malignant cell is more commonly seen in patients with high-grade lymphoma than low-grade lymphoma. And MRI is the most widely used test for initial staging, assessing treatment responses, and conducting follow-up care in patients with NHL. Decreased LDH levels are common in patients with NHL and are correlated with an increased tumor burden. So is it the A, the FDG PET, higher predictive value for relapse than CT? Is it B, the lymphocytosis with circulating malignant cell is more commonly seen in high-grade lymphoma than low-grade? Is MRI the best exam, or is LDH decreasing is the common symptoms in non-Hodgkin lymphoma? So please vote. So as we can see, the majority voted for the response number A. I can say that our audience is responding better than the one of Medscape quiz done previously. We are having the same almost percentage, but we have 60% for the response for the A question, for the A option, and for Medscape it was 50%. So yes, we know very well that the whole body fluorodeoxyglucose has a higher predictive value than classical CT. That's why it should be done whenever we want to do an evaluation for non-Hodgkin lymphoma. Question number 4, which of the following is accurate regarding the treatment of non-Hodgkin lymphoma? Combined chemo-radiation therapy is the standard management for patients with indolent stage 1 and contiguous stage 2 non-Hodgkin lymphoma. The B answer, tumor lysis syndrome commonly occurs after treatment of high-grade bulky non-Hodgkin lymphoma. The C answer is early intervention in asymptomatic patients with indolent non-Hodgkin lymphoma is strongly recommended and associated with significant prolongation of survival. And finally, D, patients with intermediate grade non-Hodgkin lymphoma should receive chemo alone as the first-line treatment. So is it A, that chemoradiotherapy is the treatment of indolent lymphoma? Is it B, tumor lysis syndrome, TLS, frequent in high-grade bulky lymphoma? C, early intervention in asymptomatic non-Hodgkin lymphoma, indolent non-Hodgkin lymphoma, prolonged survival? Or D, intermediate grade non-Hodgkin lymphoma should receive chemo alone as first-line treatment without monoclonal antibody? So please answer. Can we have the answers? So again, we are doing similarly to what has been done previously in this for this question, and we see that tumor lysis syndrome is the right answer, and 51% voted with Medscape for this question, while 13 thought that non-Hodgkin lymphoma indolent should receive chemoradiotherapy, which is not the right response, and 20% said that early intervention in asymptomatic indolent lymphoma prolongs survival, which is not also right. And finally, the intermediate grade non-Hodgkin lymphoma should receive only chemo and not combined with the monoclonal antibody. So the best response is TLS syndrome, is frequent in high-grade bulky non-Hodgkin lymphoma. And the question number 5, what's the most important factor in deciding to prescribe a biosimilars tends to be the FDA approval, or EMA for some European country, the clinical trial data, the real-world data, or all of the above. So what is for the majority of people the most important factor in deciding to prescribe a biosimilar? Is it the FDA approval or EMA approval? Is it the clinical trial data, or is it the real-world data? Only one response. And is it the FDA or all of the above? Yes, indeed. The FDA is very important, but the clinical trial data also is important, but usually the FDA is based on that. And the real world data, nobody voted for it, but also it's important for later on. So the right answer is all of the above. Indeed, all of the above. Okay, and remember the real world data specifically in the biosimilar is important in my opinion. So another question, the placebo effect can impede a well-crafted treatment plan and affect the transition to biosimilar therapy, true or false? So it's a tricky question. So it's a true, it might be true, yes, probably. And yes, it's a true in this case. Finally, the last question, according to the FDA, a biosimilar is a biologic shown to be interchangeable with a reference drug already approved by the FDA. Interchangeable that we can modify. So the FDA says biosimilar is a biologic interchangeable with a reference drug already approved by the FDA, or a biosimilar is a highly similar to and have no clinically meaningful difference from a reference drug already approved by the FDA, or biosimilar is highly similar to but clinically different from a reference drug already approved by the FDA, or finally, the D choice, biosimilar is highly similar to and have no clinically manageable differences from a reference drug not approved by the FDA. So which one of these is the right question? What is, according to the FDA, the biosimilar? Is it the biologic with interchangeability to a drug already approved, similarity but non-clinical difference for a drug already approved, similarity but clinically different from a drug already approved, or is it a highly similar to and have no clinically meaningful differences from a reference drug not approved by the FDA. For sure, the last one is not the right answer. And we can see that it's highly similar to and have no clinically meaningful differences from a reference drug already approved by the FDA. Yes, when we talk about biosimilar and about FDA, it should be first approved by the reference should be approved by the FDA, and probably yes, it should be highly similar and have no clinically difference from the reference drug, and it's the right answer. The B is the right answer. So according to the FDA, a biosimilar is a biologic that is shown to be highly similar, never equal, highly similar to, and have no clinically meaningful differences from the reference drug monoclonal antibody that should be approved by the FDA initially. Okay, thank you. With that, I finish my presentation, and I leave the floor for Dr. Sami Al-Khatib to present Dr. Khalid Ibrahim, our colleague.
Thank you, Dr. Fadi, and I'm really happy that the answers of our audience, it was much better than the answers done by the others. So really happy from the audience. Now it's my pleasure to present Dr. Khalid Ibrahim. His hematology and medical oncology at Hammoud Hospital University Medical Center in Lebanon, and he will talk about heparin-induced thrombocytopenia type 2, report on a case. The lecture is recorded, and please, Vanessa.
Good evening. First of all, I start by apologize because this presentation should have been done 1 week ago, maybe more, but it was the same day when Dr. Ghassan Hammoud left us, so I couldn't have it. So I like this slide. Usually, I put it whenever I present something stasis, and it's something that was coined by G.H. Levy, telling that everybody love equal hemostasis, that everybody talks about it. Nobody understands it. Actually, it's one of the most perplexing chapters in hematology. Now, talking about thrombocytopenia and the hospitalized patient, it's it's an important topic. It's most common hematology consult. It's more common in surgical trauma patient than medical patients. Most common hematological issue in ICU patient, and each one of us deals with this on daily basis. The most important thing that it's linked with the higher mortality and morbidity, and the mortality increases by 4 to 6 times if thrombocytopenia is sustained for more than 4 years. So it's an important thing to deal with from the beginning. And it's a marker of serious medical illness, independent, this is important, of bleeding event. So it's important whenever we are approaching this to take into consideration the history, if we had prior thrombocytopenia, chronic problem or not. No history of thrombocytopenia, of course, helped to exclude many common causes like liver disease, malignancy, ITP, sometimes TTP, as we'll see later on. Physical examination is very important, and peripheral smear is important. Peripheral smear to make sure, first of all, that if we are dealing with a true thrombocytopenia or it's factitious thrombocytopenia, like problem aggregation. That's why platelet clumping, of course, and other. And that's why sometimes the practice is so-called finger prick, because finger prick, some of the people, they do below aggregation on EDTA. So finger prick sometimes can help us, especially in a situation where you don't expect the thrombocytopenia. Next slide, please. I'm going to omit this slide. Next slide. So whenever we are approaching thrombocytopenia in the hospitalized patient, we should focus more on the most serious life-threatening conditions, like heparin-induced thrombocytopenia, immune-mediated and drug-induced thrombocytopenia, DIC, microangiopathic hemolytic anemia, sepsis, and multifactorial ICU thrombocytopenia, which is related in the majority of the case to the polypharmacy that the patient received in ICU. Now, if we stratify our patients with acquired thrombocytopenia with shortened platelet survival, now we stratify them as associated with bleeding. Whenever you're talking in this situation, you're talking about ITP, most drug-induced thrombocytopenia, and many others. On the right part of the slide, you see conditions that are associated with thrombosis, like microangiopathic hemolysis, heparin-induced thrombocytopenia, Trousseau syndrome, DIC, and antiphospholipid antibody syndrome. It's an important entity that we encounter sometimes in ICU. Next. Now I'm going to discuss the first. Actually, the intention was to discuss two cases, but because of the shortened of time, we selected with Dr. Farhat to present this case. 49-year-old woman with a history of lupus, hypertension, stroke, admitted with a cellulitis and possible UTI. She was started on IV antibiotics and heparin 5,000 units sub-Q for DVT prophylaxis. By the way, it's a common practice in many centers and even many countries. On the 7th day of hospitalization, she developed a platelet count of 66,000 when it has been normal previously, even after 48 and 72 hours. She also developed a left popliteal DVT. How would you approach this problem? So what do we have in our hand? Possibility of heparin-induced thrombocytopenia? Maybe. Immune-mediated drug-induced thrombocytopenia? Maybe. DIC? Well, less likely. Microangiopathic hemolytic anemia, actually on the peripheral smear, we didn't have any schistocyte, and this applies also to the IC because this is something that we see also in sepsis and multifactorial ICU thrombocytopenia. And this is a very important here piece of information because whenever you are approaching all these, of course, we should not forget about the lupus and possible antiphospholipid syndrome. But it is a crucial thing. It is a crucial thing because at this part of the time, we should take action. Well, probably should think about heparin-induced thrombocytopenia, and it's important to think about it. Now, what is this entity, heparin-induced thrombocytopenia? By the way, heparin was discovered in the early 19th century, and it took time to understand that heparin is an anticoagulant, and also took time, you see the timeline of this story, if you want, and it took also time to understand that heparin can induce thrombosis, and in the mid 80s, we started to understand that there is an immune process going on causing thrombocytopenia in one part of the story and thrombosis in the second part of the story. Next slide, please. Heparin is a very common thing that we use on daily practice. It's one of the most commonly administered parenteral therapies in the hospital setting in general. You can imagine that 1 trillion units of heparin are used per year in the USA, and 12 million patients are exposed to heparin per year. Well, you know, it's a huge number. It's one big country. Indications of anticoagulation also are increasing. And the other thing, that the documentation of heparin usage is inadequate, because you know, now if you go in your hospitals, everyone, and you don't check if your patient is receiving prophylactic low molecular weight heparin. I mean, we are using less and less unfractionated heparin. Yeah, I don't understand, except in the open heart or in some catastrophic situations. But in general, we don't check with our residents, our fellows, if we are giving, because it's going as you know, as a practice in general. Now, what are the heparin preparation that we're using? We're using the pentasaccharides, like fondaparinux. We'll a little bit discuss this later on, which is an heparinoid but it's a very, 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 very low molecular weight. And this is important because if you look at this scheme here, as much as you have more molecular weight, heparin became more antigenic. So that's why it's one of the wisdom by using low molecular weight heparin in comparison with unfractionated heparin. Next slide, please. Now, what usually happens here? It's very simplified. It's a immunological response reaction that happens between heparin and the platelets factor 4. This becomes a complex, and this complex at the end of the day will be unified with an immunoglobulin, and this immunoglobulin will attack platelets, and once it attacks platelets and the platelets are activated, they release serotonin. Because of this hyperactivation of the platelets, as you all know, in the new model of coagulation, the activation of platelets ends by having a thrombin burst, and based on this, you will get the thrombosis. So it's an immune process between exposure of heparin PDF4, then an immunological complex. This immunological complex will attack the platelets with a serotonin release, and this is an important thing because, as we'll see later on, this serotonin is one of the things that we search to confirm if we have heparin-induced thrombocytopenia. Next slide, please. Now, HIT is a profoundly hypercoagulated state. It's not. Our patient will suffer from thrombosis more than bleeding. You will rarely see a patient with HIT bleeding. In the majority of the cases, it's a thrombosis. And as I told you, it's an iatrogenic disorder, usually mediated by immunoglobulin G antibody that binds to PF4 heparin complexes. And this will cause the hypercoagulated state by activating the platelets and secreting procoagulant, micropactyl particles. Next slide, please. So 1/3 to 1/2 of patients with HIT, they develop venous, arterial, or microvascular thrombosis, which means not everyone with HIT will develop thrombosis, and this is something that we'll see during the course of the presentation. Next slide. And the unfractionated heparin is associated with 10-fold increase in risk of HIT compared with low molecular weight heparin, which means that low molecular weight heparin can also cause HIT. Next slide, please. What is the course of HIT? Either we have a rapid onset of HIT for patients previously exposed to heparin. Typically, patients develop HIT within 4 to 14 days of heparin exposure, and the last possibility is to delay the delayed onset of HIT with average of 9 days after heparin is stopped. Next slide, please. How would we approach this? We cannot approach it just by suspicion. That's why it is recommended to use the so-called the HIT 4 T's. The first T is thrombocytopenia with more than 50% decrease from the baseline. The second one is the timing, because timing is 5 to 10 days. I mean, in the HIT type 1, you can develop thrombocytopenia within 24 hours, 48 hours, and there's nothing to be done here because this is a transient thing that will stop alone. And this is important in the ICU patient. Usually we see it in the ICU or surgical patients. It's not an indication to stop heparin if you are developing it after 24 to 48 hours, except if you have an exposure to heparin. And this is important whenever, as I told you, whenever we are approaching patients with ICU, to see, to take a good history from them, just to consider the possibility of HIT or not. The third T is to exclude thrombocytopenia of other possibilities. Well, many things that you can encounter, especially in the intensive care unit. And the last T, if we have other reasons for thrombocytopenia. What about our patient? Our patient had a decrease more than 50% of the baseline. She developed thrombocytopenia within 5 to 10 days. We have a confirmed thrombosis. Sorry, the third T is confirmed thrombosis. I mix it with the last one. If we have a confirmed thrombosis, in as much as she had a popliteal one, and we didn't have in our hand another cause of thrombocytopenia. Now the score is from 0 to 3, and if the first one is 2 points, then 1 point, then 0 point. It's important to use this. For the time being, this is the most important tool that should have it, and our resident, our fellows on the floor, our nurse, they should have this scale, because whenever you are sitting in the closed area, especially, the possibility of hit is there. So it is the way how to approach. We don't approach it in like a German philosophy, as we say, either toto or not. Well, we should do this scale, and we should put our points according to it, because if you have a score of 0 to 3, hit is unlikely, and no need for confirmatory testing. This is important, because the confirmatory testing, it's it's time consuming and it's money consuming. So if we are ordering it in a non-random fashion, it's not a good practice. Now, it scored more than 4, you perform the PF4 antibody. Your PF4 antibody, as I told you, it's the immunoglobulin. It's a quantitation of the immunoglobulin complex. If you have antibody, if you have it, it's one way to go. And the other thing that we can search for is what? Is to see the serotonin. As I showed you, that serotonin is being released abundantly whenever you have an activation of platelets. Now, next slide. Especially whenever we have this suspicion. So the first of all, so in our patient, we have a high probability based on the 40T score. Based on this, as it is recommended, what should we do after that? We have a high 40 score. We go and we jump to what? First of all, we do the immunoassay, and if it is positive, then you can perform a functional test, which is the serotonin test. Next slide. These are the 2 assays that we use for the time being, and we hope that we will having in the future a more refinement of these tests. The first test is the so-called heparin-PF4 ELISA. This test is highly sensitive. It's up to 90%, but it's low specific. Why? Because you can get a positive result here without having hit. On the other hand, whenever you are approaching serotonin release assay, it's highly specific, but it's lower sensitive. So that's why those 2 tests are complementary. But whenever we have a suspicion of hit, we don't wait for these. These are confirmatory tests. The most important is the 40 score. Next slide, please. So our patient 40 score indicates high probability, as I told you, for hit, and you have sent for the hit ELISA. Currently, your patient is receiving subcutaneous unfractionated heparin twice daily. What should we do? Next slide. We stop heparin definitely, and we start non-heparin anticoagulant at therapeutic dose. And let me tell you this, whenever we're talking about stopping heparin, this doesn't mean only to stop the subcutaneous. It means that we should not use anything related to heparin. No cannula, no flushing, nothing, no heparin. It's a contraindication to see heparin on the floor, no heparin. And this is an important thing, an important message for our nurses, if we have nurses in attending, or even our junior residents and fellow. no heparin at all. Next slide, please. Then this patient, HIT laboratory test results came to be that the immune assay, the ELISA result, they are reported as an optical density, somewhat optical density, it's 1.8. Normal optical density is less than 0.4. This is a very important indicator that we're really dealing with HIT. And after that, we asked for the serotonin release assay. Next slide, please. So what are the recommendations of the American Society of Hematology? In patients with acute HIT complicated by thrombosis, some HITT, or acute HIT without thrombosis, isolated HIT, the panel recommends discontinuation of heparin and initiation of non-heparin anticoagulant. It's a strong recommendation with moderate certainty. What did the panel suggest? Is to use the argatroban, bivalirudin, danaproid, fondaparinux, or and a direct oral anticoagulant. So what is the rationale? What is the rationale for anticoagulant selection? So using a non-heparin anticoagulant compared with stopping heparin plus or minus starting VKA, and we're gonna talk about the VKA later on. It's associated with fewer thrombotic events, but probably can cause more bleeding. And the important thing that we don't have direct comparison between DOACs and the parenteral anticoagulant like argatroban or like fondaparinux. And we have a small number of patients treated with DOACs in case series. Some of them, and this was also an argument in the recommendation of the American Society of Hematology, that in many series, the few thrombotic events were observed whenever they were using rivaroxaban versus apixaban versus dabigatran. Of course, there wasn't a direct comparison, but it's in the series. These were the results. Next slide, please. So how would we use these drugs? So the clinical context is very important. Whenever the critical illness increased, the bleeding risk and possible or urgent procedure, argatroban, bivalirudin, with shorter duration and effect are recommended here. And if we have a moderate or severe hepatic dysfunction, it's advisable not to avoid argatroban. This is an important thing whenever we want to use these drugs. Now, in the second clinical context is whenever we were dealing with the life or limb threatening VTE, massive PE, or venous limb gangrene, parenteral and non-heparin anticoagulant is preferred, argatroban, bivalirudin, danaproid, and fondaparinux. And the last clinical context is whenever you have a stable patient with average bleeding risk, fondaparinux and DOACs are reasonable options. Next slide, please. What about our patient? Next slide, please. So our patient was started on fondaparinux, and these are the dosage of fondaparinux. By the way, we don't have in Lebanon argatroban or bivalirudin. So the recommended dose, if the patient is less than 50 kilograms, it's 5 milligram per day daily. If 50 to 100, 7.5, and more than 100, it's 10 milligram daily. This is a therapeutic dose. We should make sure that our creatinine clearance is good because this drug is a renal metabolite. Next slide, please. After 3 days of starting fondaparinux, we started the patient on rivaroxaban as 15 milligram twice daily for 3 weeks, and then 20 milligram daily. In case of isolated HIT, well, we didn't have an isolated HIT. It was complicated with thrombosis. In case of isolated HIT, it's 50 milligram twice daily until platelet recovery, which means we need platelets of 150 and more. And this is a very important surrogate to be taken into consideration whenever we are giving our treatment. The target is to get the platelets more than 150,000. And if we don't get it, which means that our patient is resistant, and we should get it within 5 to 7 days, it means that our patient is resistant, and probably we should think about other possibilities of treatment. Next slide, please. Please don't use warfarin. Warfarin can cause a transient hypercoagulable state associated with low protein C and S. It's a contraindication, as you see on the right side of the slide. It's contraindication to use it. We use it only whenever the platelets are 150,000 and more. Our patient continues rivaroxaban 15 milligram BID for 3 weeks, then takes rivaroxaban 20 milligram daily for a total of 3 months. It's a provoked thrombosis, and it's recommended to use it for 3 months. Now, at 3 months, we had another problem. At 3 months, his platelet count were normal, and he's at baseline health status. You ask him to stop rivaroxaban. By the way, the patient started to increase the platelets after 7 days, and it was increasing steadily. And when the patient was discharged, his platelets were more than 150,000. Now, what happened after 15 months? He returns to the hospital with congestive heart failure again, and is found to have severe aortic stenosis with an aortic valve area of 0.6 centimeters square centimeter, and he requires a valve replacement. What should we do now? Next slide. What next? What should we do? We need a surgery. And this patient had a HIT. So our patient with the history of HITT requires open heart with intraoperative anticoagulation while on pump. His platelets count is normal. You repeat the HIT ELISA, and this is a recommendation. You repeat the HIT ELISA, and the OD is 0.2, which is less than 0.4. It's normal. What should we do here? The recommendation is, as I see, it's not the right answer. What the recommendation is to give intraoperative heparin only. And we should take also into consideration that we have 5 phases of HIT. The first phase is a suspected HIT, where platelets are decreased. We don't have a result of immunoassays. We don't have a functional assay. This is the suspected HIT. The second phase is the acute HIT, where platelets are decreased, and you have the immunoassay and the functional assay positive. The subacute HIT A, where platelets are normal, but the assays are positive. The subacute HIT B, where platelets are normal, only the immunoassay is positive. And this is something that I was telling you, that sometimes the immunoassay is positive, but you don't deal with HIT. So that's why the sensitivity and the specificity differs between the functional assay and the immunoassay. And the last one is the remote HIT, where you have a normal platelet count, normal immunoassay, and normal functional assay. So what are the recommendations of the American Society of Hematology in patients stating like that with subacute HIT B? And bas ELISA and normal plates and ELISA positive, or remote HIT where everything is normal, who requires cardiovascular surgery. The panel suggests intraoperative anticoagulation with heparin rather than treatment with a non-heparin anticoagulant, plasma exchange, and heparin or heparin continued with antiplatelets agent. This is a thing that we don't know for the time being. So in this situation, what we use heparin, and we use it in a limited time to the intraoperative setting. Full stop. After that, if we need the anticoagulant, we shift to other forms of anticoagulation. My last slide, we could have been discussed for many instances, and in this situation, what should we do whenever the patient is not responding properly to anticoagulation, whenever the patient is not responding probably having an increase in the platelets count. Well, we have a lot of variation, but we have a limited time, and maybe if I can make it, we can discuss it in the Q&A session. Now, what are the areas of future investigation? First is the development of novel HIT immunoassay and functional assay that are more accurate that we have in our hand. We don't have a clear-cut outcomes from treatment of acute HIT with DOACs. It's an early. We don't have a lot of patients. We have some reported series in centers. We don't have a comparison of DOAC and parenteral no heparin anticoagulant like I was talking about. We don't know the role of concomitant antiplatelets and anticoagulant therapy in HIT. We don't know the impact of screening of asymptomatic DVT in acute isolated HIT. We don't know the optimal duration of anticoagulant in acute isolated HIT. And the intraoperative anticoagulant management of cardiovascular surgery, we are still putting our, giving an unfractionated heparin whenever our patient is being put on the pump. Can we use something else? This is also, these are the big questions we don't have for the time being, and these recommendations are the 2021, the ASH 2021. What about immunoglobulins? What about the use of steroids? So many questions. I think it's my last slide. The most important thing and the most important message from all this presentation is to have a high suspicion index and think always about the possibility of HIT. Although it's a rare condition, it's 1 or 2 per million, but nevertheless it happens in the big centers, especially whenever you have open heart or orthopedic surgery. I will stop here and I will be glad to take questions whenever I can. Thank you very much for your attention.
Thank you, Dr. Khalid, for the excellent lecture. I think Dr. Khalid is not going to be able to be with us to answer the questions. So please join me to welcome our next speaker, Dr. Farzaneh Ashrafi. Dr. Farzaneh she is Hematology and Medical Oncology at Isfahan University of Medical Sciences in Iran. And she is going to talk about evolving management of patients with double hit lymphoma. So we are welcoming you, Dr. Farzaneh, as we are welcoming all our participants and attendees from MENA area. Dr. Farzaneh, the floor is yours.
You are muted, Dr. Farzaneh, you are muted. Yes, no, it's okay. Hi, and can you put it in a slide view?
Yes.
How are you?
Fine, thank you. Hi, and hope you'll be well. It's my pleasure to be invited in this webinar, and I am discussing the evolving management of double hit lymphoma. I've got some problems with internet. I hope that this doesn't impair my presentation.
We are hearing you very clearly.
Good, thank you. The objectives of my talk is about the diagnosis of double hit lymphoma, genomics in double hit the prognosis and the best management of the patients with double-hit lymphoma. As you know, the diffuse large B-cell lymphoma is the most common lymphoid malignancy in adults. Almost 35 to 40% of lymphoma in Western countries are diffuse large B-cell lymphoma. And the estimated incidence is 7 to 8 cases per 1,000 per year. The peak incidence of diffuse large B-cell lymphoma is in the 6th decade. A better understanding of the genomic markers associated with the response will directly allow the development of the patient selection strategies that only treat patients who are most likely to respond. And for this purpose, we have discussion about the different molecular subtypes of DLBCL. As you know, based on the molecular subtypes, we have germinal center B-cell-like lymphoma and activated B-cell-like lymphoma based on the molecular subtype of diffuse large B-cell lymphoma. And we have Hans algorithms for definition of different molecular subtypes of DLBCL based on the IHC pattern. And based on the CD10 expression in the IHC, we have germinal center B-cell lymphoma if the CD10 is positive. If CD10 is negative, then based on the BCL6 in IHC, if BCL6 is negative as well, we have non-germinal center. And if the MUM1 is positive non-germinal center, and in the patient who is CD10 negative, BCL6 positive, MUM1 negative, we have germinal center B-cell lymphoma. Double-hit lymphoma or high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement NOS based on the WHO 2016 criteria. We have two entities that should we differentiate between these two: double-hit lymphoma and double expressor lymphoma. Double-hit lymphoma is defined based on the rearrangement of the BIC with BCL2 or BCL6. And it constitutes about the 10% of germinal center B-cell like DLBCL. But DLBCL with high MYC, more than 40% plus BCL2 protein expression by IHC without genetic rearrangement is called double expressor lymphoma. And majority of double-hit lymphoma are germinal center B-cell-like, and majority of double expressor lymphoma are ABC-like. And data that we have from the database of chromosomal alterations in cancer, 62% of these newly categorized MYC rearrangement lymphoma involve BCL2 translocations, and 80% involve BCL6 translocation, and the remaining are triple hit, rearrangement of the MYC, BCL2, and BCL6. And as you know, in this graph, if we have blastoid lymphoma, Burkitt-like DLBCL, and DLBCL NOS type. If we have MYC rearrangement, we have only MYC rearrangement, it is Burkitt lymphoma. And if we have MYC rearrangement with BCL2 rearrangement, we have high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. And this category is the double-hit lymphoma. And in this graph, you see that the MYC rearrangement constitute about 12% of the biopsies with DLBCL morphology. And if we consider cell of origin in DLBCL patients and the fish pattern in these patients, we see that if we have MYC and BCL2 rearrangement, both of them, for approximately 5% of patients are germinal center B-cell-like. And if we have triple hit presentation in the fish pattern, about 1.7% of the patients, it is germinal center B-cell-like. But if we have MYC and BCL6 rearrangement, it may be germinal center or non-germinal center. in the cell of the origin of the lymphoma. And high-grade double hit, triple hit lymphoma is approximately 8% of tumors with Dlvcl morphology. What about the clinical characteristics of the double hit lymphoma patients at presentation? The median age of these patients is about 78. They are more advanced, stage 3 or 4, more high Ipi score, high LDH, and extranodal site involvement, including CNS involvement. What about the overall survival of the double hit patients and double expressor lymphoma patients? As you see that the worst prognosis in the DLBCL patients is double hit lymphoma patients with MYC and the BCL2 or BCL6 rearrangement. Double expressor lymphoma patients in the prognosis and the survival are between the non-double expressor and double hit lymphoma. And the patients who are not double expressor or double hit lymphoma have the best overall survival. What about the treatment in the double hit patients? In the double hit lymphoma patients, the treatment with CHOP or R-CHOP is unsatisfactory. As you see in several studies with different patients, the patients with double hit lymphoma characteristics, the outcome is very poor. And for example, the only response is the response rate in the several of these ends. But if the initial treatment is changed, the event-free survival of the patient will be better. For example, in this study, you see that when the initial treatment of the patient changed to the R-Epoch, the event-free survival of the patient was better and the overall survival of the patient was better in comparison to the R-CHOP or other high-dose therapies. Another factor that constitutes the prognosis of the patients with double hit lymphoma is the Ipi score. The patients with higher Ipi score had worse prognosis, like other diffuse large B-cell lymphomas. But the type of the rearrangement does not influence event-free survival, and the event-free survival between the MYC and BCL2 or MYC and BCL6 rearrangement or triple hit lymphoma is the same. Overall survival of the patients who treated with the regimen of R-Epoch are better than other regimens. And as you see in this curve, that the R-Epoch in these patients have better overall, produce better overall survival in the double hit lymphoma patients. Another factor that should be considered in the double hit lymphoma is the rate of the CNS lymphoma, CNS involvement in these patients. Double hit lymphoma who has a bone marrow involvement and the performance status 2 or more had approximately 13% of the CNS involvement. And if we use CNS prophylaxis with the IT, the rate of the CNS lymphoma decreased from 50% to 5%. We can use in the double hit lymphoma from a prognostic score that constitutes leukocytosis, stage, LDH, and CNS involvement. The subset of patient who has not any of these items has better prognosis than other patients who had 1 or 2, 3, 4 of these items. And these are actually a minority of double hit lymphoma patients. between different regimens, different intensified regimens, the dose-adjusted Ipi has produced better complete remission rate in the patients with the double-hit lymphoma. And the PFS improvement was better with those patients that has been treated with dose-adjusted Ipi. Another option is that patients who have received stem cell transplantation in the first complete remission has no overall survival advantage. And CNS prophylaxis produced overall survival advantage 14 versus 45 months. And this is a huge advantage in overall survival with CNS prophylaxis in these types of patients. In the double-hit lymphoma who has been treated with autologous stem cell transplantation in first complete remission, no improvement in event-free survival or overall survival was seen. And in summary, aggressive B-cell lymphoma, we have Dlvcl type or high-grade B-cell lymphoma type. In both of them, we have double hit, triple hit, or double expressor lymphoma. If we diagnose double hit, triple hit, the cell of the origin of most of the patient with double hit, triple hit is germinal center B-cell origin. In double expressor, the cell of origin of this type of the lymphoma is likely ABC type. For the treatment of the patients with double expressor, we use trials or R-CHOP, but for double hit, triple hit patients, we use dose intense regimens, and the best of them is the dose adjusted Ipi. And we use consider CNS prophylaxis for these patients, for patients with double hit, triple hit, for better overall survival benefit. And there is no role for autologous stem cell transplantation in first complete remission in the patients with double hit or triple hit lymphoma. Thank you for your attention.
Thank you very much, Dr. Farzana. It was really nice. And I would like to open the floor for question if there is any. So if you have any question, I think it was very clear, Dr. Farzana.
Thank you very much.
And we thank you for your participation and hope to meet you soon again. It was
hope to see you again. It was my pleasure to be invited and speaking in your webinar. Thank you very much.
Thank you. We appreciate it a lot. So now we will move to the next presentation. The presentation, I will be doing it. I am Fadi Farhat. So it's biosimilars in an era of rising oncology treatment options. So we will be approaching a bit the subjects of the biosimilars. I see here we had a question. We will come back to it if Dr. Farzana will stay with us. So we know very well that nowadays there is a new concept introduced, which is the financial toxicity. And we can see here that there is a big cost of cancer care nowadays, and we can see it while the GDP is increasing modestly. The payment for the health care and specifically for cancer medicines and drugs is increasing highly and quickly. And we see that chemotherapy and immunotherapy with monoclonal antibodies were doing the highest expenses. We can see that the monoclonal antibodies as immunotherapy are among the highest, and rituximab, for example, was the fourth by expenses in 2018. And we know that while the income is stable, the expenses for healthcare are increasingly, and thus we can see that many of patients will not be able to spend correctly for their healthcare. And why we are talking today about biosimilars, because the cost of healthcare is rising. There's a great variability in cost and quality across systems. The patients has an increasing share of the expenses out of pocket, and this might impact the quality of treatment and the decisions for the treatment and the outcome also. So since we are talking about biosimilar, what's the biosimilar? A biosimilar is a biologic product that is highly similar to the reference product. So as we said in the quiz, it should be highly similar to the reference product, and we cannot say equivalent like in generic we say bioequivalence. Here we talk about similarity to the reference product, notwithstanding minor differences in clinically inactive components and no clinically meaningful differences between the biologic product, the originator, and the reference product in terms of the safety, purity, and potency. So it should be highly similar to the reference product. There should be minor differences in inactive component, and most important, no differences between the biosimilar product and the reference product in safety, in purity, and in potency for the product. And we published a paper in 2017. At this time, it was rising as subject. It was the concept of biosimilar with our team and with the American Miami team. And biosimilar are biologics. What make them different from the chemical? First of all, for the manufacturers, the chemical drug are reproducible, easy reproducible. They are identical copies, so you can make the same API ingredient, active pharmaceutical ingredient, what we call API. While biologics are coming from living cells or organisms, and it's impossible to produce the same. So even if the company will change the place of production, this might need a new approval. So from the manufacturer's point of view, in chemical drugs, we can reproduce the same, but in biologics, it's impossible. The stability is relatively stable for chemical drugs, but it's not, it's totally unstable for the biologics. And the immunogenicity is an important point for the biologics, while it's not for the chemical drugs. Also, we can see that when we talk from the small molecular to biggest, we can see the size be different. So antibiotics, for example, are really low molecular weight, while increasing with the biologics, and the minor one is also bigger, like Vilcastream. When we reach the monoclonal antibody, the size is huge, and also the structure is different. Look to the structure from the antibiotics going to the biggest molecule with monoclonal antibodies, what we call the dinosaurs. So remember, these are in the factory coming from bacteria, while the others are from living cells. Also, we can characterize them easily when it's antibiotics compared to the monoclonal antibody, which is impossible to fully characterize the composition of the molecule. In always, FDA will approve the pathway for biosimilars. So there should be a specific pathway. They start by the analytical study. And remember, at each step, FDA will assess the different steps. Analytical studies, then after animal studies, then after they go to pharmacokinetic and pharmacodynamic studies, and then clinical immunogenicity assessment. You see the immunogenicity is important, which is not the case in regular drug. And then after, they will need a clinical study. And again, at each level, the FDA will be controlling to see if there is any uncertainty about biosimilarity of the proposed product. And as you can see, it starts by the molecular characterization, the preclinical, pharmacokinetic, and the clinical before the submission to the market, and then post-marketing. And if you want to extrapolate, we'll come to that later on. We will need convincing evidence to support the extrapolation from one indication to another. That's what we are, that's the meaning. So what's the justification for biosimilar extrapolation? The monoclonal antibody in each condition should be similar binding, molecular signaling, similar location expression of target receptors. For example, if we use the rituximab in the non-Hodgkin lymphoma, follicular or diffuse large B-cell, and since we have the approval of the this molecule monoclonal antibody in CLL, can we use it? So this is the extrapolation indication from an indication to another. So we should have a similar binding for the molecules, like for example, HER2 positivity in breast, in gastric or others. Yes, we should have a similar binding effect of the drug. Pharmacokinetic and biodistribution in different population, relevant pharmacokinetic measures might also inform of the importance of monoclonal antibody. The immunogenicity might be different in different patients' population. The toxicity might be minimally different in each condition of use of target indication patients. So these are some important factors when we talk about extrapolation. And remember, some countries will accept easily the extrapolation while some others will not. Variability and the drift, significant difference in drug products can arise due to the production at different sites. And remember that change of manufacturing process after initial approval will lead to sometimes resubmission. And it was the case of the cetuximab when Merck Serono decided to change the site of production. They had to reapprove. Why? Because it's not a pharmaceutical ingredient, simply it's a living cells producing these molecules, these dinosaurs, these monoclonal antibodies. So manufacturers need to be vigilant for any changes in production and must always assume that they can result in clinically significant issues. And it's very important to say, since we are talking about biosimilarity, similarity, so it's close to, but it's not the same. It might be a bit less potent, bit more potent, efficacious. Okay, so both biologics and biosimilar are subject to product variability and the drift. And the immunogenicity is a big concern, even if it's rare, but it's a concern for all biologics, not only the biosimilars. Consequences, it might lead to the loss of the efficacy, might lead to the neutralization of endogenous protein and administered biologic agent, and it might lead to an immune general response like allergy or anaphylactic shock. And FDI guidance regarding immunogenicity assessment will require a comparative parallel design in a treatment-naive population. So that's why you will find that the FDI will not approve if there's some trials in second or further line. So they need a treatment-naive population that had never received such a treatment in order to avoid any previous immunogenicity. And the FDI will ask for evaluation of patient, of subset of patient for substantive descriptive assessment of immunogenicity with a single crossover from reference product to biosimilar. So in some case, I will ask to switch from the reference to the biosimilar in order to check for the immunogenicity. So immunogenicity is also important, and the interchangeability and substitution. What does it mean? The definition of interchangeability requires higher standards than biosimilarity alone. Must have same result when switched, alternated with reference product. So when you say interchangeable, it means that if I prescribe a drug, if it's not available or for any reason I cannot have access to it, I can change to another medication. So it's allowed apparently to go from one to another, but not to change all the time from one to another biosimilar. Interchangeable biosimilar may be substituted without intervention of provider. So in some cases, it doesn't need the intervention of provider. So, however, must first be approved by FDA as interchangeable. So you might have a drug approved as biosimilar, but in the FDA, you should have it as biosimilar and interchangeable. So apparently, this is the data from 2008, 19, 20. No biosimilar in the US has been designed as interchangeable. Remember, the case might be different in different countries. For example, in US, in EU, European Union, or in Japan, for example. So when you say biosimilar again, it means that clinical results are as the reference product. So we have the same efficacy to the originator as the biosimilar. When you talk about interchangeability, you should have the same clinical result as the reference, but also you should have the same clinical result when you switch or alternate with the reference product. So, for example, if I don't have the originator, the MabThera rituximab, and I have to be sure if I switch to the another rituximab biosimilar, I have to be sure that it was accepted or it's assigned as biosimilar and interchangeable. This is mean the standard is higher, and this is mean that we have to get more approval. And again, it's different from a country to another. So look to the upper one, the upper schema. The approval process required too large amount of data. You know, usually for any product, we need phase 1, 2, 3, and then 4 post-marketing approval. For the biosimilar development, also we need a lot of information to go for the approval. We have to repeat the clinical trials in some to the phase 1 or 2, and in some case we have to do more data phase 4 post-marketing. So this will get from that we'll have a benefit that the healthcare professional will have a greater confidence in the biosimilar product, a greater acceptance of the biosimilar, and more safety confidence. But the risk in such cases when we need a lot of data for the approval, will have higher development costs and low pharmacoeconomic benefit over the innovator. So if we are repeating the same steps, means we will have the same cost. So we will not have probably the pharmacoeconomic benefit by reducing the cost in order reducing the cost of the development in order to reduce the cost for the patients. If we decrease the criteria for the approval, in this case, the benefit will be the decrease of cost for development, which means decrease of the cost for the biosimilar. But on the other hand, we will have lower healthcare confidence in this product and less acceptance probably for this biosimilar, and more safety issues with such a product. And if we talk about that, it's true that we have what we call biosimilar, this product that went through all the development steps, while we have what we call in some countries biocopies, or these molecules that have not followed these step of development, that might, for some of our doctors and some of our patients, that might have more concerns about the quality, about the risk of immunogenicity, about the efficacy. So as you see here, it's a balance, and we have to talk and discuss with the policymaker and with the patients about what is feasible for us in our countries. So the ASCO statement about biosimilar: generic must be bioequivalent and pharmacological equivalent simply. Reference product is single biologic product licensed by FDA standard against which proposed biosimilars are evaluated. Biosimilarity is highly similar, never equal, is highly similar to approved product, demonstrated to have no clinically meaningful differences versus reference product, and I saw you voted for that. Interchangeability meets biosimilarity standard, expected to produce same outcome as reference product, and for biological products administered more than once, safety risk and risk of diminishing efficacy when switching from reference product is less than continuing reference product without alternative switching. Please read again this sentence, and you can see that the biological product administered more than once, safety risk and risk of diminishing efficacy when switching from reference is less than continuing reference product without alternative switching. So it's better to switch whenever we can, better than not switching at all, not having this product. Remaining challenges for us. So first of all, will biosimilar be accepted and used in different countries? The USA was so rigid, while 20 or 30 years ago, biosimilars were introduced in the European Union. The USA simply for the last 5 years started really to use biosimilar. So it depends on countries. So are biosimilars going to be accepted everywhere? Will biosimilar help to reduce the healthcare costs? For sure, yes. Will biosimilars improve patient access to biological agent? Yes, probably, and reduce disparities in cancer treatment, different economical status of the country. So ASCO guidance said biosimilars will play an important role in the future care for patients with cancer and will improve access to valuable medicine. So yes, the ASCO approved that the biosimilars will be helpful, but still there is the concerns for the physician and also for the patients who are aware about their disease. Physicians are skeptical of efficacy, safety, and are concerned to use this drug, and probably they will be forced to do that because of the economical heavy weight of expenses. And physician perception will be that cost is the main issue. Strong clinical data will be important for acceptance, and educations will be essential to accelerate uptake after approval. National meeting and online education, that's what we are doing, might be helpful. So, and we need experts, we need unbiased data that focus on clinical data. So again, there is some concern from the healthcare professionals to accept concerning the efficacy and safety, and it may lead to a decreased acceptance. And also We had another paper on biosimilar in 2016. At this time, I was very interested by the biosimilars. And we did a survey about biosimilar prescription and challenges in the Middle East and North Africa region during our Lebanese Society of Medical Oncology and Pan-Arab meeting. And we had observed, I'll not go through the detailed data, but there was some concern. And at this time, even the knowledge of physicians about it was really modest. So we have some challenges and some opportunities. We went through it, I will not go again, but I would like to take the example of one of the pharmaceutical Novartis, which went through a different pathway than others. While others, for example, Roche, never decided never to enter in the biosimilar pathway. Some different, like Amgen, thought to buy other company. Pfizer went and acquired the Hospira, which is a biosimilar company, and generics. So different pathway. While Novartis, which is previously Sandoz, growth into Novartis, kept Sandoz as the generic and a biosimilar company. And we know all that nowadays we are using a lot of Sandoz product, which are Novartis products indeed, and they are located in different regions in the world. And Sandoz are leaders in this field, a lot of experience with, for example, in Lebanon, at least we have 7 approved products of Sandoz in Lebanon that we are using. And indeed, while we are stick to the quality of drugs, in Lebanon, we accept the generics and biosimilar that are really FDA or EMA approved. So we take the example of Sandoz, and we take the example of the rituximab brixaton in non-Hodgkin lymphoma. And we can see here that the development of the biosimilar will take into consideration all the totality of evidence, starting by the analytical, preclinical, pharmacokinetics, up to clinical confirmation, and that the post-marketing. And we can see here that the clinical efficacy was produced was confirmed with the trial Assist FL, where it was a double blind. You see, again, we repeat the same as the originator in phase 3. It's multi-center, it's randomized, it's double blind, phase 3 clinical trial. In this case, it was for follicular lymphoma. And look to the number also, it's a big number of patients, 315 almost in both arms, randomized to receive either the biosimilar or the reference medicine with chemotherapy, the same backbone chemotherapy, and also maintenance with the same schema for both for both group of patients. And the objective was to compare the efficacy, safety, pharmacology, and immunogenicity of the biosimilar compared to different medicine. The primary endpoint were the response rate at the end of the combination phase, and also other outcomes were important. And also, sorry, it's important to say that safety endpoint were adverse event and immunogenicity. And we can see here that in the Assist FL trial, the response rate is similar between both. And you might find in some cases that the biosimilar has numerically higher. It doesn't matter. So we have the same CR and the same PR, numerically higher CR in the biosimilar, but non-significant statistically. We will say also that the adverse events were similar, and the immunogenicity was also similar, low in both cases, with 0.7% in each arm. So the toxicity profile was equal, and the efficacy. So, and the biosimilarity of Rixathone, the biosimilar of the rituximab, was supported by the superimposable pharmacokinetic and pharmacodynamic profile. So here we are giving an example of the biosimilar development of drugs. And look here to the reference drug. It's compared or superposed to the biosimilar one. And as in the chain of development, we have also to take in consideration the post-marketing studies, because in such a drug we might have in our real life also some let's say some additional data. And here one of the trial is the OncoTract real world evidence, and it was non-Hodgkin lymphoma in an oncologist network in Germany. So it's our daily practice. They used the Rixathone in 1,241 patients with non-Hodgkin lymphoma and 500 CLL. So as you can see, the trial was in follicular lymphoma, but it was extrapolated to this indication since the receptors are the same. And we can see that this trial was conducted in 23 centers and 71 patients. So it's a huge one. And here are the percentage of disease: follicular lymphoma, CLL, diffuse large B-cell lymphoma, and other non-Hodgkin lymphoma. And let's take a look to the result. It was 64 received biosimilar and 36 received the reference rituximab in the diffuse large B-cell, and the CLL almost 50-50. And the biosimilar usage at the beginning was only 12% when they started the trial, but then after, as in every case, the drug will gain more and more confidence, and by the end the biosimilar usage was 83%. And this indicate the acceptance of the new biosimilar indication, extrapolated indication with the doctors. And the second trial, the REFLECT, it was a first real-world post-approval data for a rituximab in diffuse large B-cell lymphoma. The primary endpoint was the CRR, and it was assessed by the treating physician. The secondary endpoint was ORR, PFS, adverse event, quality of life. The number is not a huge 170, and we can see that in this trial, the summary of safety result showed that we had a serious adverse events treatment related in 7% only, while 31 not related to the treatment, low number of death, low number leading to discontinuation, and adverse event requiring dose interruption or change, also low number, 6 related and 8 not related, and additional treatment 17% related to the drug addition treatment were needed. So interim results of safety reconfirmed the expected safety profile of diffuse large B-cell lymphoma treated R-CHOP in the real world, R-CHOP rituximab, but in this case is what the Rixathone. And the data showed that we have disease control PR plus CR in almost 88%, which is confirming the efficacy of the R-CHOP in Dlvcl. So the conclusion was it's the first real-world post-approval data of Rixathone in diffuse large B-cell. Interim baseline supported, as expected, the use of this drug in the CD20 DLBCL, and it will help so that it will help to reduce the cost, and it will extend the number of patients treated, and probably this will help to sustain the cancer care. And it's good to know that new drugs like biosimilar, as I told you, might have a bit higher or lower efficacy, and so also difference in stability. For example, the Rixatone have superior stability compared to the originator. So Rixatone need a shelf, doesn't need a specific temperature, and it's really as for the pharmacist, it seems that it's easy for them to use it, and it doesn't need a specific storage like the other drugs. I will not stop on that since we are not pharmacists. But from that, from this presentation, I will go to the take-home message. First, are available for the last 5 years in USA, but it was previously approved in Europe, and nowadays it has been integrated into clinical practice guidelines for the majority of indication. Remember that the acceptance of biosimilars will depend on the monitoring, continuous monitoring on safety and efficacy, and really the integration will need from our side as doctors, pharmacists, and nurses to make a pharmacovigilance and to keep controlling these toxicities. Education is important. Education not only for the healthcare professionals, but education with regulatory instances, and the post-approval surveillance also is also important. And here the example of Novartis, the mother company, Sandoz, the generic and biosimilars company, and the baby Rixatone drug, the biosimilar Rixatone, confirmed the sustainability of the system using the biosimilar in specific indication, and here it's hematology and non-Hodgkin lymphoma. And with that, I finish, and thank you for your attention. And please, if you have any question, let us know to discuss it. Dr. If you are with us, there is a question from one of our colleagues. Other than EPOC, you can see it in the question and answer. Other than EPOC, no other updates. I think it's a question or it's a comment. No, other than EPOC, no other updates.
There are several trials trying to find another treatment options for double hit, triple hit lymphoma patients. We have a phase 2 study about adding the lenalidomide to R-CHOP in the non-germinal center B-cell lymphoma. Some of these patients has had double hit lymphoma. The overall survival and event-free survival of the patient in this trial was around 60%, but the toxicity was higher in this regimen. We have a phase 2 study about adding the venetoclax in the R-CHOP, venetoclax to R-CHOP in the high-grade B-cell lymphoma patients. And in this study, some of the patients, around 10%, was double hit lymphoma, but the toxicity of this regimen was higher. And until now, the best regimen for treatment of the double hit lymphoma patients is dose-adjusted EPOCH-R. Other high-dose regimens are like hyper-CVAD rituximab or R-CODOX-M, R-IVAC regimens have a response rate and event-free survival around 70%, but they are more toxic than the regimen of dose-adjusted EPOCH-R regimen in the double hit lymphoma patients. And the best regimen for this type of the patients is the dose-adjusted EPOCH-R. The dose adjustment in the EPOCH regimen is very important. And the base in this regimen is that we escalate the dosage of the etoposide in this regimen with nadir of the neutrophil count in the previous cycle. And the best result is with those adjustments in the EPOCH-R regimen, not only EPOCH-R.
Thank you very much. I think your presentation was well welcomed because it's interesting, really. Another question, what's the difference between double and triple hit? You mentioned it in the presentation, but maybe you can give a small response again, hint.
When we have the rearrangement of MYC with the BCL2 and BCL6, it is named the triple hit lymphoma. And this is the minority of the patients in the double hit lymphoma category. Is there any effect of the triple hit lymphoma, of the type of the rearrangement with MYC in the outcome of the patients? This is the basic question. But in the studies, it has been shown that there is no difference in the outcome of the patient between double hit with different partners with MYC or triple hit lymphoma patients. The outcome is the same, double hit or triple hit.
Okay, so again, another question just sent. What is secret in EPOCH? Is it the etoposide or methotrexate? I mean, I presume that why it's the efficacy of the EPOCH? That's the question, probably.
In the regimen of the EPOCH, we have intrathecal in each cycle, intrathecal methotrexate in each cycle, and we have etoposide in the regimen. We have 24-hour infusion of the drugs, and 24-hour infusion of the drugs reduce toxicity of the regimen without changing the potential of the regimen, efficacy of the regimen. And another point in this regimen is dose escalation based on the nadir of the neutrophil in the previous cycle. And I think that these characteristics of this regimen make this regimen the best type for treatment of double hit lymphoma patient with a high potency regimen and less toxicity than other high dose regimens like R-Hyper-CVAD or R-Codox M-IVAC regimens.
Okay, I would like to, I see there is no more responses. We are still at 50 participants, which is excellent at this time. I think that we can stop here. So first of all, I would like to thank all the attendees. I would like to thank our speakers, specifically Dr. Farzana. It was really very informative and interesting. And I would like to thank Dr. Sami Khatib, who left us now for another meeting, and Science Pro, the organizers. And finally, I would like to invite you for our next session in 2 days. It's about GU cancer, and I think you will like it as you like this one. So, au revoir, bye-bye, ila al-liqa, khuda hafiz, and see you in 2 days. Bye-bye.
Bye-bye, khuda hafiz.